Thank you for joining us for this afternoon's emergency town hall following the effective date of a government shutdown and the expiration of telehealth expansion waivers. For those of you who are new with us, my name is Lydia, and I am the policy analyst here with the Center for Telehealth and eHealth Law. We are a research institute based here in DC with a focus on advising health leaders and policymakers in the development and integration of digital health services. So just to start with the basics of what a government shutdown is, this comes as a result of the fact that Congress must fund the federal government through legislation. This is directed by the Constitution, which gives Congress, the only branch of the federal government directly elected by constituents, the power of the purse, which means that it is Congress's responsibility to write legislation both concerning the raising of revenue as well as distributing where those funds get spent. And so Congress typically does this through annual appropriations cycles following a fiscal year, starting on October 1st of each year. However, sometimes Congress does go off different times depending on how long it decides to fund the government. And so if Congress does not pass a bill to fund the government, or if a previous bill that had funded the government expires, the federal government enters a shutdown where activities that are deemed non-essential are put on pause, and employees who are engaged in those non-essential activities are furloughed. And so each agency in the federal government has a plan in place for if it does enter a shutdown, including HHS and CMS. And these plans are typically posted publicly online, detailing what activities will continue and what activities will be suspended during a shutdown. And so we are currently in a shutdown because the most recent bill to fund the federal government, which was a continuing resolution passed back in March of this year, did so through the end of the last fiscal year, which expired on September 30th. So at midnight this morning, the funding for the federal government officially expired and it entered a shutdown. This is important because tied to the funding for the federal government were telehealth waivers, specifically regarding Medicare reimbursement for telehealth in expanded circumstances. And so during the COVID-19 pandemic and associated public health emergency declaration, Medicare restrictions on telehealth reimbursement, such as originating site, eligible clinician types, and hospital care at home, were waived. However, after the expiration of the public health emergency and relevant authorities, Congress decided to continue allowing for Medicare to expand its reimbursement of telehealth in expanded circumstances. And so Congress eventually tied these extensions of these waivers to bills that also funded the federal government. That's why when Congress extended funding for the federal government back in March through the end of September, it also did so for telehealth waivers to the same date, which is why at the same time the government shutdown began, so did the expiration of these telehealth waivers. And so just a very brief background as to why a shutdown is happening now. The House earlier in September passed a continuing resolution which more or less kept funding levels at the same, effective through November 21st. Now, this is a pretty short-term continuing resolution, considering that the last one that was passed back in March did so for about 6 months. This is because there is bipartisan interest from both Republicans and Democrats in Congress to put together a full slate of 12 appropriations bills. And so these bills would, rather than just keeping funding at the same levels or making small adjustments to funding, would be full-fledged bills with funding directed towards each agency. And so there's interest amongst both Democrats and Republicans in putting together those bills. However, those bills have not been put together fully yet. And so the idea was to give Congress a few more weeks to get these bills put together and to go through a full appropriations process. However, this bill, once it made it to the Senate, was rejected by Senate Democrats. And so this meant that the bill fell short of the 60 vote threshold needed to end a filibuster and pass a bill through the Senate. One of the reasons that the Senate Democrats rejected this CR was that they wanted to see an extension of enhanced ACA premium tax credits, which are set to expire at the end of this year. And so Democrats introduced their own counteroffer CR, which included this and other policy provisions, and that bill also failed in the Senate. Now, the House, after it passed its continuing resolution back in mid-September, recessed through the end of September as a way to put pressure on Democrats in the Senate to pass their bill as is. And Senate Democrats chose not to do so. And so without that 60 vote threshold, both plans for keeping the federal government open failed in the Senate. Another piece of pressure that was put on the Senate to pass a continuing resolution to keep the government open was a directive issued by the Office of Management and Budget to agency heads saying that rather than just furloughing affected employees by a government shutdown, that they should make plans to lay off and eliminate their positions entirely. And so the specific directive that was issued by the OMB told agencies to identify positions that would be affected by a lapse in appropriations or generally did not align with the president's priorities, as the memo said. I want to make a note of the fact that telehealth was not a target, nor was it something that there's much interest in Congress in seeing expire. It is more so a casualty through this process because Congress decided to tie the telehealth waiver extensions to bills to fund the federal government. When the bill to keep the federal government funded failed, so did the telehealth waivers. There is still a bipartisan interest in keeping telehealth expanded and seeing more access to digital health services. However, because it was tied to this issue, it is also seeing an effect of the lack of a bill passed. And so obviously the big question is what happens to Medicare reimbursement? And so Medicare is a mandatory program, and so it will continue to work and reimburse for eligible services throughout the duration of a government shutdown, although these payments may be delayed due to administrative limitations. CMS has also indicated that certain services like beneficiary casework, policymaking, education and outreach, and others will be suspended during the course of a government shutdown. Of course, the big question today is telehealth. And so the expiration of these waivers meant that Medicare no longer has the authority to pay for telehealth services in expanded circumstances. It is not that Medicare doesn't have the money to pay for these services. It's that the law that governs Medicare's reimbursement of telehealth services no longer allows for expanded circumstances that it can reimburse for telehealth, and that such Medicare only has the authority to reimburse for telehealth services under the pre-COVID standard since the expiration of these waivers. I also want to note that lawmakers have not indicated whether they will reauthorize the waivers alongside a deal to reopen the government, nor have they indicated that if these waivers are reauthorized, back payments for services furnished during that lapse will be issued, specifically services furnished that would be eligible under the waivers but otherwise not be, if there would be back payments for those. Many of you probably already saw this email that was sent out this morning, but just in case, I wanted to read through it with you all. This is directly from CMS, and it says that when certain legislative payment provisions, quote, extenders, are scheduled to expire, CMS directs all Medicare administrative contractors, MACs, to implement a temporary claims hold. This standard practice is typically up to 10 business days and ensures that Medicare payments are accurate and consistent with statutory requirements. The hold prevents the need for reprocessing large volumes of claims should Congress act after the statutory expiration date and should have a minimal impact on providers due to the 14-day payment floor. Providers may continue to submit claims during this period, but payment will not be released until the hold is lifted. Absent congressional action beginning October 1st, 2025, that's today, many of the statutory limitations that were in place for Medicare telehealth services prior to the COVID-19 public health emergency will take effect again for services that are not behavioral and mental health services. These include prohibition of many services provided to beneficiaries in their homes and outside of rural areas and hospice recertifications that require a face-to-face encounter. In some cases, these restrictions can impact requirements for meeting continued eligibility for other Medicare benefits. In the absence of congressional action, practitioners who choose to perform telehealth services that are not payable by Medicare on or after October 1st may want to evaluate providing beneficiaries with an advanced beneficiary notice of non-coverage. Practitioners should monitor congressional action and may choose to hold claims associated with telehealth services that are not payable by Medicare in the absence of congressional action. Additionally, Medicare would not be able to pay some kinds of practitioners for telehealth services. And then the bottom paragraph just goes over specific exceptions for shared savings program ACOs. And so one of the big asks that we're seeing from the telehealth community is for Congress to, if they do reauthorize the waivers, to allow for retroactive payments or back payments for services furnished during the lapse of a waiver. And so one of the big questions is, well, can Congress do that? Can Congress issue retroactive laws? These slides are from a CRS report on it. I won't go into too much detail, especially on some of the case law. But if you're interested in reading more, there's a citation on the next slide. Specifically, the Supreme Court has noted that retroactive penal laws are unconstitutional due to the ex post facto clause. There's also the due process clause that places certain restrictions on Congress's ability to apply retroactive laws. However, there is no blanket ban on retroactive laws, and that it is very much contextually and situationally dependent on the specific bill and circumstance. And the citation for the CRS report reference is at the bottom as well. And I'll put the slides in the chat at the end of the presentation as well. And so with this, we can look at, well, has Congress done retroactive Medicare payments in the past? And we see some instances that Congress has authorized back payments or retroactively increased payments for certain services, especially throughout the 2000s due to payment cuts issued through the sustainable growth rate formula through Medicare. And so these are just a handful of instances where Congress has authorized back payments and retroactively blocked certain payment cuts or payment restrictions before. The situation might be a little bit different since this is rather than authorizing a payment bump or blocking a payment decrease, this is payment for an entirely different set of services in expanded circumstances. But we do see that there is a history of Congress in the past authorizing certain retroactive payments for Medicare before. So there's no reason, while Congress has not indicated whether or not it will provide for back payments, we do see that in the past, it is something that has happened before. And so the big question, I'm sure for all of us, is what do we do moving forward? Part of this is the fact that there has not been much guidance from CMS until that email I read to you all that was sent out this morning. And so a lot of practices have responded in very different ways. And these responses have largely been a factor of patient population, financial standing, and proportion of patients and visits losing eligibility for Medicare reimbursement. We have seen a number of different responses and contingency plans that were put in place, especially as we came closer to the event of a shutdown. Some practices have suspended their telehealth services entirely. Others limited their offering of telehealth services only to those that they know would be eligible. Others have started providing those ABNs and offering telehealth services only for out-of-pocket payment. And some, especially the larger systems, have continued offering telehealth services as normal. We've also seen some practices rescheduling their patients to a later date with the hopes that by the time those visits come around, that Congress will have reauthorized the waivers. And there have been a number of different responses. The QR code on your screen here leads to a link to download CTeL's waiver expiration and contingency planning worksheet, which is designed to help you kind of think through some of these questions as well. And so that's what I have in terms of the content for today. I'll put the slides in the chat, but I would like to open it now up to some Q&A, and feel free to type in the chat or unmute and ask any questions you may have.
Lydia, this is Joe. Nicely done. Thank you. What's your perception of the extent to which Congress is conscious of the impact that the shutdown is having upon Medicare reimbursement for digital health?
For sure. It's if you have been following it, you may know that telehealth has definitely not been in the center of the conversation for sure. It's not something that Congress particularly wants to get rid of. There's been broad support for telehealth, especially over the past few years from Congress. We saw that when, for example, the House Ways and Means Committee passed a bill providing for a longer-term extension of telehealth flexibilities, that those got unanimous support from both Democrats and Republicans on the panel. And so this kind of lends to the fact that this is something that is more so a casualty rather than a target. It has definitely not been front and center in the conversations. Democrats have focused on the enhanced premium tax credits and their impending expiration, as well as other health issues, like the Medicaid cuts that were made earlier this year, as well as other restrictions on executive authority to withhold spending that they want to see implemented. However, telehealth has not been a central rhetorical point, and at least any of the discussions that we're seeing from congressional leaders publicly.
Thank you.
Just looking through some of the questions in the chat. Any guidance on how to interpret the exception for behavioral health? How will CMS carve that out? And so there's a few questions about that. I would like to note that as indicated in the email from CMS, that there is an exception to behavioral and mental health services. The access to these services was made permanent through a different piece of legislation a few years ago. And so those are being treated differently under this circumstance because different legislation provided for reimbursement for those services.
Can I make a point? A few of us in Kentucky at our recent state conference talked about specifically behavioral health, and it was I'm an attorney and several of the others were too. My disclaimer, I'm an attorney, but not your attorney, is that behavioral health is exempted, but it has to be strictly the behavioral health codes that CMS allows. So if you're doing med management or something related to a behavioral health code, that the waiver may have expired for that. So definitely, if you're moving ahead with your behavioral health, our advice was check your codes, make sure you're billing accurately behavioral health codes only. Sorry, Anna White's, Kentucky.
Thank you. Yes. I see Dana, you have your hand raised.
Hi, thank you so much. I also wanted to point out that in adorn with the American Psychiatric Association, so we obviously are also paying very close attention to the telehealth flexibilities as it relates to behavioral health. I do know there's a law on the books at the federal level that says that patients receiving mental health or behavioral health treatment care that relates to prescribing potentially are one six in-person visit within 6 months or within 1 year, depending on when they started treatment. That is something that was left over from before COVID, basically, when it was originally and has never actually been implemented. So I just want to make people aware that that is also something that you should be checking on if you're doing prescribing in this instance. Um, but for other cases of mental health, I can't speak as specifically to that.
Can I follow that up? Joy Williams, University of Kansas Medical Center. Um, I believe it depends on the schedule of those medications, and where they fall in terms of whether they're a two or where they fall in that. But I'd actually have someone else check that out as well.
Yeah, I haven't heard of anything specifically about calling out different versions of, schedule, but obviously would be interested to know.
I'm seeing a few questions in the chat about some non-Medicare applicability of this, such as Medicaid and non-Medicare patients. This is specifically for payment under Medicare. And so there, for things like Medicaid and other private payers, the state laws would likely dictate that. CTeL has a number of 50 state legal surveys that kind of go over some of these issues like payment coverage, payment parity, and other telehealth requirements at the state level. This is specifically concerning Medicare. And I see Carol is going through and helping answer these questions as well. Very much appreciate it. Let's see. Yep, how does this affect Medicaid for pediatric patients? Yep, that is a state issue as well. And if you have any questions, feel free to raise your hand and ask as well. I'm just going through the chat. Yeah, I think looking at the question on Medicare Advantage bids for future years, I think one of the big concerns, especially when it comes to Medicare policy, is that a lot of other payers tend to follow Medicare. And so, for example, we're seeing some federal employee health plans starting to put restrictions on beneficiary access to telehealth. This is also because federal employee health plans are not subject to a lot of the state telehealth requirements that do require things like coverage and payment parity. And so we are seeing those that are able to kind of putting new restrictions on telehealth as well. And so this is something that CTeL has been monitoring as well. I didn't talk too much about hospital care at home, I do want to know that that is something that is also affected by this. Earlier in September, CMS issued a notice to hospital care at home programs to start beginning to transition those patients back into the hospital, and that they needed to have those patients back in the hospital by the 30th. And so, yes, that is also something that is being affected by this. And that is also, we're seeing an expiration that CMS has been asking those patients to be returned back to the hospital. I see a question from Mark.
Hey, Lydia. So, the whole restriction around originating point for somebody like in Jessica's case where she's got 22% of her patients are Medicare based that are scheduled for telehealth appointments. Does that mean if they went to a facility and brought their mobile phone with them and conducted the encounter from a facility as opposed to from their living room or wherever else they might be, that would still be reimbursable by Medicare?
Yeah, so it would depend on the facility. There is from HRSA a Medicare telehealth payment eligibility analyzer. I'm putting a link to that in the chat that you can you can put the address of a facility, and it will check some of the HRSA databases to see if the specific requirements for telehealth. I'm also putting a link to the original statute that we can kind of look at to see what the law that is being referenced here. So I also put that in the chat as well. Section 1834 of the Social Security Act. And so that analyzer will also check some of those requirements to see if if the specific facility will fit those requirements.
Thank you, Lydia.
I see a question from Sarah.
Hi there. Thank you again for this. Question about Medicare Advantage. My understanding was that the plans are set at least through the calendar year and that also the 2026 plans have been filed. Will Medicare Advantage telehealth claims still continue to be paid for the foreseeable future, or is this also at risk?
Unless those Medicare Advantage plans, yeah, and I see Carol also responded that Medicare Advantage plans must cover what Medicare covers, but can offer more. And so there are still plans that may offer telehealth in addition to what Medicare requires or what Medicare will cover. But especially if Medicare no longer covers it, then it will not be a requirement for MA plans. And so it will be interesting to see, especially because Medicare Advantage is a big priority specifically for the new CMS administrator. When he ran for Senate, his platform was Medicare Advantage for all. And this is something that he has wanted to see expanded. And so there might be some pressure from the top to continue to ensure that Medicare Advantage offers certain services beyond what Medicare covers. However, if Medicare does not have that floor set, then it will not be a requirement of MA plans either.
Right, but the current MA plans had to file their plan documents for coverage back in June of 2024. And so their plan documents would have included telehealth at that time. Can they remove the telehealth coverage from their existing plan documents at this moment, or do they have to continue covering what was in their plan documents for this calendar year?
I'm not aware of a mechanism that would allow them to do so with such short notice within 2 months of those plans going into effect. I'm not aware of a statutory mechanism for that. If others know otherwise, feel free to chime in.
So based on that, they would continue covering telehealth in 2025 and potentially into 2026 because those plan documents were also already filed.
As far as I'm aware, again, if others have any thoughts, I'm not aware of any sort of statutory mechanism that would allow for these plans to be changed 2 months out.
Got it. Thank you.
Kim?
Yeah. Hi.
Yeah.
Thanks, Lydia.
Sorry, right.
Um, so had a question about last year in the Medicare physician fee schedule final rule, CMS expanded some things with federally qualified health centers and rural health centers, but then also expanded temporarily the definition of direct supervision to include audio visual support through December of 2025. So I know initially when the proposed rule came out, there was some conversations about how this jived with what Congress might or mightn't do with telehealth extension flexibilities. So didn't know if you had any thoughts on that, if, you know, we're going with what CMS put in the proposed rule, or if there's any concern that that might not be honored.
Yeah, so a lot of what CMS has done in its proposed rulemaking was done under what it had the authority to do. Especially in last year's rulemaking cycle, a lot of the provisions that were subject to congressional action, CMS pretty much just said that we can't really do anything about this. If it expires, then we will act like they expire. However, a lot of what CMS did have the authority to do, for example, like changing the definition of telecommunications technology to allow for audio only if the patient is not able to or not capable of doing audio video. So that was something that CMS had the authority to do unilaterally and chose to do so. There were a number of telehealth changes that were introduced or at least proposed for the 2026 rulemaking cycle. And I can share CTeL's summary of that on the screen right now. These were all things that CMS had the authority to do kind of within its own. So for example, the Medicare telehealth services list, CMS is proposing to change its methodology for what services get put on that list and not. That is something that isn't the services that are on that list isn't something that Congress is mandating, and so CMS is putting together the process for that. And so, for example, when it comes to direct supervision, this is another area where CMS had the authority to act unilaterally, and so that's when it did choose to act to make that change permanent, at least propose so. Whether or not these waivers get extended, that might change the way that CMS chooses what it does and does not finalize. But for example, when it comes to teaching physicians billing for services involving residents with virtual presence, this was something that CMS wants to propose to sunset because again, it has the authority to do so. And so when CMS is able to act on some of these more specific things on its own, it will do so. However, it has in the past acknowledged what is in the realm of Congress and what CMS has the authority to do.
Thank you, Lydia.
Sarah, I see you have your hand raised. Going through some more of the questions. If we miss any of your questions, feel free to bump it again or raise your hand and call it out. Just want to make sure we're getting through everything. Or if you just have any other questions, feel free to raise your hand or unmute while I'm looking through. Iris?
Hi, thanks for calling me out. I might have missed this, but let me ask you a question. If we were to just do a telephone visit with somebody because they're unable to do a full-blown audio-visual telehealth, is that still not covered as of the end of the extension if we do just a telephonic?
Yeah, so that would specifically be the like originating site requirements, the eligible
Mm,
requirements, everything that's under the waivers would still apply. This is just if if the patient doesn't want to or can't do an audio video, then
right.
they can do audio only. But if that audio video wouldn't be reimbursed, then that audio only also wouldn't be reimbursed.
So we can assume that we cannot replace any standing telehealth with a telephonic. But, because I know for like behavioral health, if you can prove that there's a hardship, then the patient is covered, but that is not the truth in the case of any other Medicare patient in any other service. In
Yeah,
other words, right? It's like a double negative, I know.
yeah, that when they changed the definition, that didn't change what is sort of underlyingly eligible under the statute of the Social Security Act,
Mhm.
which I put in the chat. And so even if you know, that is done via audio only, if it's not still meeting those requirements, it would
Mhm.
still not apply or be eligible because it's still
Okay.
not meeting those like rural location requirements, those facility requirements, and others.
Thank you.
Any other questions? Again, just going through the chat right now. I'll put these slides in the chat again. Just so you have them. Outlook on the government shutdown. So it looks like I just want to make sure clear that I cannot make any predictions as to what will and will not happen. Our focus with all our members have been understanding what the potential outcomes are and how you can best prepare for those. What it's currently looking like right now, I would not personally expect to see any action at least before next week. And that is because Congress will be going out of session again later this week to observe Yom Kippur, as well as the fact that there have not been any substantial movement on the negotiations. We're kind of currently seeing both sides dig into their positions. Republicans say that they don't want to negotiate until the government is reopened, and Democrats say they don't want the government to reopen until they can negotiate. And so kind of given that these two positions are digging in deeper and that we've already crossed the threshold of that shutdown and that we're in it now, there hasn't been much movement in terms of a desire from other side to see this through to the end. One of the big questions and the calculus that any political party has going into a shutdown is whether or not they can effectively pin it on the other side and whether or not they see a political benefit in having that shutdown occur. And so this, for example, was something in the previous shutdown that was about like 7 years ago or so. One of the big demands was to get that extra funding for the then first Trump administration's border priorities. And what we saw from that was that even though they had these demands and they had a very long shutdown, at the end of the day, those demands ultimately didn't get met. And so one of the questions is, will Democrats continue to hold out until they get those demands met? How long will they tolerate a shutdown? Will it be until they feel that opinion is turning against them? It will also depend on who can effectively win the rhetorical battle of the shutdown and the politics of that as well. And so we don't have a lot of recent, especially given that the last shutdown was all those years ago. But a lot of those calculations are still going to be the same. And so what we're seeing right now is both sides are digging in. We've crossed this threshold now that we're in the shutdown. There's likely not to be any movement before at least next week, I would say. Any other questions? If not, our contact information is here on the screen. You're always welcome to reach out to me or any of us via email at any time. And you can also get more information on our website at CTeL.org. If there are no other questions, then that's all that we have for today. Again, feel free to reach out at any time. We are here to support you, especially through this time period.